So good morning or good afternoon, everyone. My name is Dr. Bouchard. I'm the founder of the ACHD Hive. Thank you all for joining us today on this second episode of the ACHD Hive Talks. The theme for today is PAH in congenital heart disease, and we welcome Professor Dimopoulos for the first part of the session to give us a presentation, and then the second part of the session will be led by our panel of experts. We'd really appreciate if all the cameras were on when possible, just to make it a little bit more interactive and friendly, and audio is to be muted unless you're asking a question or participating. The second part of the session will be interactive, and so we really welcome any questions or observations or opinions in the chat, or just raise a virtual hand. So with all further ado, I pass it on to Professor Dimopoulos, and thank you very much for joining us.
Well, very many thanks for the invitation to give a talk on pulmonary hypertension associated with congenital heart disease. I'm sharing my presentation now. Let me just put it on, on presentation mode. I hope you can see that. So this is congenital heart disease associated with pulmonary hypertension, vice versa, pulmonary hypertension associated with congenital heart disease, which is probably the more accurate term. First of all, to remind everybody, this is from the National Database of Pulmonary Hypertension. As you know, in the UK, we have a designated centers for pulmonary hypertension. We have a national database, and this shows us that the idiopathic patients, the number of patients with congenital heart disease associated pulmonary hypertension are similar. So it is a large population. They tend to live also longer than the idiopathic patients. So it is a big chapter in pulmonary hypertension, and expertise is required to look after these patients. It is also important to remember that pulmonary hypertension, not pulmonary arterial hypertension, but pulmonary hypertension is present in various types of congenital heart disease. And indeed, if we look at the classification of pulmonary hypertension groups 1, 2, 3, 4, and 5, we can find congenital heart disease in all groups. Group 1, PAH, we've got the 4 groups. We will discuss about that, including Eisenmenger patients. But we've got Group 2, postcapillary pulmonary hypertension, which is probably the most numerous, the biggest population of patients with pulmonary hypertension, congenital heart disease. These are left-sided lesions, more rare, like coronary atriatum, but more common, like disease of the mitral and aortic valve that can cause, or diastolic dysfunction of the LV, or systolic dysfunction that can cause postcapillary pulmonary hypertension with congenital heart disease. We've got Group 3, patients with bronchopulmonary dysplasia or lung disease. We've got lots of patients with obstructive sleep apnea. In Group 4, we've got patients with congenital peripheral pulmonary artery stenosis. And in Group 5, we've got miscellaneous, in which we have patients with segmental pulmonary hypertension, single ventricle, and so on. Indeed, this is the classification again as it stands from the latest guidelines in 2022. And you can see congenital heart disease here in Group 1, in Group 2, in Group 3, in Group 4, and also, I mean, in Group 5 it disappeared, but it's coming back according to the latest Nice, and it wasn't in Nice actually, it was Barcelona, the World Symposium. Now, the idea of pulmonary hypertension congenital heart disease is demonstrated more simply in patients with a ventricular septal defect. So imagine having a patient with a large ventricular septal defect. When they are born, the resistances in the lungs drop because they start breathing, lungs are expanding, the pulmonary circulation expands, so resistances drop, and hence if you have a large ventricular septal defect, you have a significant left-to-right shunt and flooding of both volume but also pressure, because this is a large VSD, allows pressure from the systemic to the subpulmonary ventricle and into the lungs to cause shear stress in the pulmonary circulation. This over time causes progressive pulmonary vascular disease up to the point where the shunt becomes reversed, if we allow it to, of course. Reversed in the sense you have a bidirectional shunt because the resistances in the lungs have gone really systemic, and you have an Eisenmenger syndrome. And this is a continuum. This is a continuum because you start with a left-right shunt with hardly any pulmonary vascular disease, and as the pulmonary vascular disease progresses and the resistances go up, The left-right shunt decreases until it becomes bidirectional right to left, and you have Eisenmenger syndrome. At that point, even though there is not a strict correlation between histology and hemodynamics, usually you have irreversible pulmonary vascular disease. So you have damage that even if you close the VSD, it won't go away, and you will end up with residual pulmonary hypertension, which increases perioperative risk. So you shouldn't be closing any defects when the patients have irreversible pulmonary vascular disease. Now, we said in the group 1 in pulmonary arterial hypertension, we have 4 groups of congenital heart disease, which are very different to each other in pathophysiology and how they should be managed. We have the Eisenmenger patients, we'll talk about them, the blue patients with severe pulmonary vascular disease and reversal bidirectional shunt through the defect. We have those who still have a left-right shunt, which could be correctable or non-correctable. We sometimes call them B1 and B2. We have patients with coincidental defects, so we have a perhaps small VSD, but then significant pulmonary vascular disease. And you think, why should that be the case? Is this idiopathic? Is it coincidental with the congenital heart defects? Should this group even be in here, or should they be moved to the idiopathics with coincidental defects? And finally, we have group D, numerous patients nowadays with pulmonary hypertension after defect correction, and Professor D'Alto, who is on the panel, has published a lot on this and has shown us that if you have a high pulmonary vascular resistance, even above 5 Wood units before the operation, then you're likely to have residual pulmonary hypertension. Sometimes it happens after repairing without pulmonary vascular disease before repairing, and it happens months or years down the line. Eisenmenger syndrome. This is Eisenmenger, Professor Dr. Eisenmenger. This is Paul Wood, who systematically described Eisenmenger syndrome almost, 60 years after Eisenmenger. Victor Eisenmenger described this man, powerfully built 32-year-old. So you see, like today, we have many adults with Eisenmenger syndrome, who of course are blue and are breathless. He managed well until some point when he started becoming more breathless and developed peripheral edema, so congestive heart failure. He was admitted to hospital and given rest and digitalis. That's the only thing they could give, and then collapsed and died suddenly from a large hemoptysis. So beautiful demonstration of what we see even nowadays. We have patients with exercise intolerance, with dyspnea, who present with congestive heart failure and have a high mortality, early mortality with various with heart failure, with other complications, including hemoptysis, which we still see. Now, Paul Wood in this book has systematically described, there are 2 papers that I invite everybody to read in Circulation 1958, if I remember correctly, and beautiful papers, valid even today, describing his population of Eisenmenger patients and the pathophysiology, which still applies nowadays. This is an example of a non-Downs patient, even though this is a complete atrioventricular septal defect, as you can see, with a single AV valve with an inlet VSD and a primum ASD with severe hypertrophy of the right ventricle, but good systolic function. But you can see how this could be a stiff right ventricle, and diastolic dysfunction, Philip pressures will be high. You see the defect, which is large and goes almost into the outlet, and you can see this bidirectional shunt. There's no such thing as pure right-left shunt in Eisenmenger. It's always bidirectional, if anything, for the difference in timing of contraction of the 2 ventricles. You can see that's right to left, a little bit left to right, and then right to left again. Now, this is a tree that I created many years ago to remind ourselves that in Eisenmenger syndrome, you have a combination of cyanosis, pulmonary hypertension, and congenital heart disease, which gives you loads and loads of potential complications from exercise intolerance, hematological issues like erythrocytosis, which is welcome, of course, and unless it's excessive, thrombocytopenia, predisposition to bleeding and thrombosis, heart failure and multi-organ failure because of cyanosis and low cardiac output, and arrhythmias, and of course prone to infection with complications. And you need to be aware of all these complications if you're looking after these patients. And even though many of these patients live to adult life, not everybody. If you speak to pediatric centers like Great Ormond Street, many of patients that early in early years, in pediatric years, they develop this reversal of the shunt. Many of them die early, so it can be very aggressive, but many do find a stable, fragile stability and get to adult life. But if you have an adult patient, let's say in their 30s with Eisenmenger syndrome, they've got a life expectancy of a 62-year-old, which means there is significant morbidity and mortality. And you can see it's around, what do you say? I mean, around 20%, 15, 20% every 5 to 10 years. So significant morbidity and mortality, and despite advances in management. Um, Fortunately, we have therapies now, and the strongest data still is from Circulation 2006, the Breathe 5 study, which used bosentan, showing a significant, statistically significant and hemodynamically significant reduction in pulmonary vascular resistance, even though if you look at the data, the average PVR goes from around 35 to 30 Wood units, so nowhere near able to close the effects in Eisenmenger patients, but still a drop in pulmonary vascular resistance, which was associated with an increase in 6 minute walk distance, so an improvement in exercise capacity. And of course, that means improvement in quality of life and the ability of the patients to do more. More recently, the macitentan were used in the Maestro trial in Eisenmenger patients. There were some flaws in the designs of the study. Many treatment-naive patients who had never seen a specialist center had never seen a 6 minute walk test. So unfortunately, there was an improvement in both macitentan, but also placebo effect. This is why when you have a patient who's never done a 6 minute walk test and you want to recruit them or even interpret a 6 minute walk test, you should probably do one to show the patients how it's done, and then the second one will always be better than the first one, even if you don't do anything. So the Maestro didn't reach the primary endpoint, but there were some clear signs in objective things like NT-proBNP, which improved, and also in the invasive arm of the study where there was some improvement in hemodynamics. So some positive signs, even though we didn't reach the primary endpoint. And of course, we have non-randomized, but still important data from Michele D'Alto and data from Italy, Hungary, and Greece, showing that even triple combination or prostanoid treatment, mainly treprostinil, in Eisenmenger patients can lead to a significant improvement in walk distance, in BNP, in PVR, and cardiac index. And of course, this is important data because it's probably the strongest data we have on combination therapy and the use of prostanoids. Now, few patients were in propranolol because there are concerns with regards to bubbles going to the systemic circulation causing systemic emboli or an infection of the lines that can cause endocarditis. And so when available in the UK, this hasn't been available in the past until recently. Treprostinil, probably subcutaneous treprostinil, is probably the first choice for prostanoids in these patients. And this is most of the data was with treprostinil. Very strong data. Many years ago, we published from the Brompton data with statistical analysis to account for differences between patients on therapies and not on therapies, showing that at that point there was a clear effect not only on exercise tolerance, but also on outcomes, on mortality by giving these therapies. At that point, there was lots of debate. Is this true? Is this not true? We've got at least 4 or 5 other papers from large registries, Germany, Australia, etc. I think France as well, that have shown similar outcomes. So it is clear that when you have a patient with Eisenmenger syndrome, you treat them not only to improve their exercise capacity, but also to improve their outcomes. Now, there are other things we should be doing with patients, especially if the secondary erythrocytosis, we said that these patients, we expect them to have a raised hemoglobin, and this is to increase the oxygen carrying capacity of the blood. You said this patient is blue, there's blue blood going to the systemic circulation. How can I get more blood to the tissues, more oxygen to the tissues? I make more hemoglobin and carry more oxygen to the tissues. Of course, that requires iron, and we have shown that giving oral, also intravenous iron, can be safe in these patients. in patients, especially we have a hemoglobin lower than predicted. Most of these patients were cyanotic Eisenmenger patients. You see many of them have a hemoglobin of 15 or 150 grams per liter, and that is too low for patients with saturations in the 80s. And of course, you give iron to improve on that and to improve also the Krebs cycle and other things where iron acts. And there is a significant improvement in exercise capacity if we do that. Of course, when you give IV iron, you need to be careful with bubbles on the lines and systemic embolization, paradoxical emboli. Other complications in Eisenmenger patient we need to be aware of is the progressive dilatation of the pulmonary arteries, which happens not uncommonly and can be dramatic, like in this case with a young woman with an ASD Eisenmenger. ASDs, Eisenmengers, we can debate what an ASD Eisenmenger is, but bidirectional shunting with severe pulmonary vascular disease who had a progressive dilatation of pulmonary arteries to the point where he had developed in situ thrombosis over 12 years and also atelectasis, so big that it was obstructing pathways. She had hemoptysis recurrent and she was sent to heart-lung transplantation. Now 6 or 7 years ago, she's still alive, doing well. This is what can happen, of course, if the pulmonary artery dilates and suddenly you have a hemoptysis or you have a hemothorax and you die. This patient died within a few minutes from this X-ray, unfortunately, and this is a dramatic event. So the mortality in Eisenmenger patients is high still. If we compare historical data, Paul Wood and then D'Aliento 1990s to nowadays, you can see that the mode of death has changed a little bit. Nowadays, we have more heart failure. You can say maybe that's the price to pay for our successes in keeping the patients alive a little bit longer, but then they develop heart failure, and this is driving mortality nowadays. And of course, infections are a complication. Lower respiratory tract infections, especially, are a major complication that can cause heart failure and progression towards death. Hemoptysis has been a little bit more rare nowadays, even though it still happens, it's still a mode of death. And peri-procedural, we don't send Eisenmenger patients or any PH patients to procedures that are not absolutely required. They're certainly not in centers that are not don't have anesthetic and perioperative support for PH. So you see how the peri-procedural deaths have decreased over the years, fortunately. Now, we did say there is a risk of paradoxical emboli. There is risk of in situ thrombosis, but do we anticoagulate all our Eisenmenger patients? No, we don't, unless there are indications. If you have in situ thrombosis, if you have arrhythmias, recurrent arrhythmias, a paradoxical emboli, then you need to think about anticoagulation. Warfarin has been what we've been using. These are interesting data from the Germany, which I find hard to interpret. They said that NOACs are used increasingly in congenital patients, but there is a risk of increased bleeding and increased mortality. This is not our experience, and I'm waiting for other data to support this or refute this data, because we are using NOACs increasingly, and other studies have not shown this adverse effect of NOACs in congenital heart disease, especially in the cyanotic patients. I understand with Fontan patients or other populations that are at increased risk of thrombosis, maybe NOACs are not sufficient, but not for Eisenmenger patients, in my opinion, but that's my opinion. What we want to do with our patients is to bring them, like is recommended for idiopathics in the guidelines, from the red to the green area, so reduce their risk factors, improve the function class, improve the 6-minute walk exercise capacity, improve their BNP and their hemodynamics. Now, the cutoffs provided for idiopathics do not apply to Eisenmenger patients, and we need to be, of course, careful, but the concepts are similar. We have lots of predictors of death published over time in Eisenmenger patients. We have 6-minute walk test, but with different cutoffs, as I said. Albumin, BNP as well, published by Gerhard Diller. And we have echocardiographic parameters. This is in circulation a few years, probably 10 years ago now, by Pamela Mosseri from France, who was with us, and Wei Li. where we used a composite score of TAPSE. TAPSE on its own is not sufficient to give you prognostic information, but if you combine it with other parameters like the area of the right atrium and ratio to left atrial area, and also the systolic to the diastolic time on tricuspid regurgitation, which means that when we have a well-functioning RV, you see there is ample time for diastole and systole, whereas when the RV goes off, it becomes dysfunctional and the heart rate increases. There is pre and post-systolic contraction of the RV, there's incoordination, and there's hardly any time for diastole and filling. Of course, increase your heart rate with a little bit of atrial tachycardia on that, and you lose your cardiac output. So we showed that combining these parameters in 1 point for each, you can get good outcome, good prognostic power. Of course, arrhythmia is also a risk for decompensation and death. We showed this with Maria Dracopoulou from Greece, showing that in pulmonary hypertension congenital disease, including lots of Eisenmengers, we had lots of arrhythmia, and patients with arrhythmia were at increased risk of death, not only because arrhythmia is a marker of progressive disease, but also because arrhythmia triggers decompensation and can cause early heart failure, rapid heart failure, and death. Cardioversion in a specialist center is recommended. Now, the biggest data in Eisenmenger patients is from this study by Alexander Kemeny. This is a multi-center study. We had Michele D'Alto, we had UK, and around the world, including China and the US, and showed that these are the 5 more easiest, simple but powerful parameters that can predict outcome in this population of over 1,000 Eisenmenger patients. AIDS, the presence of a pre-tricuspid shunt, absence of sinus rhythm, lower oxygen saturations, and the presence of pericardial effusion. This is the latter one is a little bit careful when you have Down's patients who often have pericardial effusion, not as a sign of heart failure or severe PAAs. And Alex has also provided this helpful table, which I think wasn't in this paper, but he published it subsequently. Now, very quickly to mention about pregnancy, we said we all know that pulmonary hypertension is a significant risk factor for complications around pregnancy. Lots of big registries. Just to mention, I think the biggest populations come from China, where these patients, almost 100 patients over a few years, present with pulmonary hypertension related congenital disease, 30 Eisenmengers. This is a specialist center. The many patients presented late, and still the maternal death was low. In Eisenmenger, 16%, which is half of what is usually described, around 30 to 50%, or a quarter of that. And but the majority of patients went to heart failure, and this is in a specialist center, so they save their lives, but many patients going heart failure, and obviously there's we need to see where this patient goes on after that, whether the condition deteriorates or not. Enough for Eisenmengers. Let's look into group B PH-CHD. So these are patients with congenital heart defects and left-right pulmonary vascular disease and left-right shunts, which pulmonary vascular disease can be mild or can be more severe. Of course, if they have reversal of the shunt, they don't fall into this category, they fall into the Eisenmenger patient. So these are, if they have significant pulmonary vascular disease, this is what some people call pre-Eisenmenger. So significant pulmonary vascular disease, not yet blue, but still not repairable because the pulmonary vascular disease is significant. So you have patients who can be repaired because the pulmonary vascular disease is low, or you can do a treat and repair and lower the pulmonary vascular resistances to where they are operable. But of course, patients with more severe pulmonary vascular disease should not be repaired. And that's why you divide them into B1 and B2, which I would call predominantly reversible pulmonary vascular disease. So repairable or treat and repairable, and those with predominantly irreversible pulmonary vascular disease. As we said, reversible is a histological thing and hemodynamic thing, and there is confusion and disagreement between histology and hemodynamics in the literature and in clinical practice. Now, remember there was the World Symposium of Pulmonary Hypertension 2024. They agreed with us in the paper about um, pediatric pulmonary hypertension, agree with us that there should be a B1 and B2. They also agree with treat and repair, but of course they want to change the wording of treat and repair because they think it should be called multimodal treatment approach in expert centers or something even more complicated. I think we should be calling it treat and repair. I think it's a nice idea. It's a nice concept. It tells you that you need to treat with pH therapies, and is the pause that you need to take, allow the pH therapies to work for a few weeks or a few months, recatheterize, and then think about repairing. If we look at the guidelines, they give us cutoffs, and I'll put them in this picture, easier to follow. For post-tricuspid shunts, post-tricuspid shunts are some defects after the tricuspid valve, so VSDs, PDAs, AP windows. They say if you have PVR of less than 3 Wood units, then you're okay to close, and the same for pre-tricuspid shunts, so post and pre 3 and 5 Wood units are the cutoffs. Up to 5, you're probably okay to close, even though the indication is a little bit softer between 3 and 5. Above 5 is where the confusion starts. For post-tricuspid shunts, send them to specialist centers. So the guys in the meeting here in the panel are the ones who have to deal with these patients without any evidence or limited evidence. For the post-tricuspid shunts, they're a little bit more. For the pre-tricuspid shunts, the ACHDs, there's a little bit more evidence, a little bit more guidance. They say, well, if the PVR is above 5 and it's not too high, it's not Eisenmenger patients, you can give them pH therapy, and if the PVR drops below 5 Wood units, then consider closing. Of course, if it doesn't drop or if it's very high to start with, then forget about it. We usually have cutoffs of PVRI of 4 and 8. We wrote lots of papers on that. The latest guidelines forgot about all that. The World Symposium has brought this back into discussion. I'm completely confused, and we can discuss about this. It just reflects that whatever cutoffs you use, PVRI 4 to 8 or the 3 and 5, this is all based on limited evidence, and it is the concepts of low, moderate, or more severe pulmonary vascular disease that we need to keep in mind rather than actual cutoffs. The treat and repair, as I said, is a theory that still is attractive to most of us. So you say, what is the concept of treat and repair? I have a patient, for example, with an ASD, but with pulmonary vascular disease. But the ASD is still causing significant left-to-right shunt, so it is overloading my right ventricle, which at this point is overloaded not by only pressure because of the pulmonary vascular disease and the pulmonary hypertension, but also volume. And that can't be good for the RV. So you say, well, if I treat with pH therapies and reduce the resistance, maybe I get them to the pulmonary vascular resistance that is repairable. And when I repair that, they say with fenestration, with a small fenestration, in case the pulmonary vascular disease afterwards is high and you need a relief valve, but you repair it, you abolish the volume overload, and therefore the RV must be happier after that. Well, there's lots of evidence in ASD. The long-term outcome is still lacking, but it still seems to work in many patients. But we need careful perioperative monitoring and careful long-term monitoring. We don't want to end up like this. This is data from Galliet's team, from Alessandra Manes, showing that if we compare the 4 groups and we have remember D, PAACHD was the repair, then they have the worst outcomes because what you've done is you've closed the defect without allowing a relief valve, and they may do worse. So you don't want to get to that. And Michele has shown us from this paper that be careful your PVR before closing is above 5 because it's likely you're going to have a high PVR afterwards as well. And you need to continue with pH therapies and monitor carefully and think carefully whether you should be closing this defect or not. Most of these cases are ASDs, but some VSDs as well. So it's not just about pre, but also post-tricuspid shunts. This is what I was telling you about, is this lack of clear correlation between hemodynamics and histology. This is from Padua, where I did my specialist training. They have a big tradition of biopsies in these children, especially, and they did cardiac. This is from ages ago, so they were doing reversibility with oxygen at that point. But anyway, and you see that you've got histology grade 4, so irreversible. But look, there are 4s that drop their pulmonary vascular resistance to actually very low levels, which makes no sense to me. And there are grade 3s that actually have very high pulmonary vascular resistance that doesn't really drop much. So this is just to show how much confusion there is in the data, in the sense that even if we were doing histology, which we're not doing anymore because it's too high risk, it doesn't give us clear answers anyway. Having said that, repairs are becoming a predominant population. This is Greater Ormond Street data. You see the biggest population of PH-ASD pediatric patients is the repair. They're coming our way. They're high risk, and we need to be prepared for them. This is a risk score that Andrew Constantine has produced, and we're trying to publish on classifying risk in patients with repaired PH-ASD. This is mainly for pediatric patients, but quite good discriminative power. The good news is that we have therapies and evidence, even though it is indirect evidence, because these patients were included in the large randomized trials for macitentan and also for selexipag, and we can now treat these patients, the repaired patients, with PH therapies and escalate to combination therapy early if needed. These are some data on just to remind you that if you have, again, like Michele D'Alto showed us, if you have PAH before closure, you probably have PAH after closure. This is a case we did, and we took an RV, which was volume and pressure overloaded. We put a fenestrated device. You see the RV looks a little bit smaller. So we took the volume overload, even though the pulmonary vascular resistance didn't really drop much by abolishing the shunt. We didn't expect it to drop much. Her walk test increased significantly, and there is still some left-right shunt, but it's not as severe as before. The patient feels much better. Did we do a good thing or not? Important to remember this for the experts in the team, that there is this concept of de-recruitment of pulmonary vessels after abolishing a shunt. What does this mean? This is an important concept because it means that there is evidence that when you have a shunt, we have increased pulmonary blood flow. When you have an ASD, vessels in your lungs that are normally closed are opened up to accommodate the extra volume. If you increase the area of the pulmonary vascular bed by opening normally closed vessels, what you do is you artificially drop your pulmonary vascular resistance. So you go, before you close the shunt, you measure a pulmonary vascular resistance. It's relatively low. Let me close the defect, and then you find a PVR which is higher than you had before. I've seen it again and again. This is, I think, must be de-recruitment of vessels. I think this is important not to have any illusions that our pulmonary vascular resistance would drop significantly after closing a defect. And most of the evidence we have with treat and repair says that PA pressures drop. They don't have a hemodynamic data, most of them afterwards. They don't give you PVR. They say the mean PA pressure goes down. Of course, the mean PA pressure goes down because you've reduced pulmonary blood flow in the lungs. Doesn't mean that the PVR has dropped. This was American data. This is data from Japan. You can see how the PA pressure drops, but not to normal levels. These are data from China, beautiful fenestrated device. And again, you can see the mean PA pressure dropping after closure. But what does that mean? Does the PVR drop? We don't know because they haven't done hemodynamics, invasive hemodynamics. What they have shown, however, is what I was telling you before. You do treat and repair to abolish the volume loading of the RV, and hence what they're seeing is that the RV size drops, and hence that must be beneficial to the RV. Of course, depending on the severity of pulmonary arterial hypertension prior to closure of the defect, you are more and more likely to have residual pulmonary hypertension. and of course the outcomes are worse. So what about post-tricuspid shunts? We said that most of the treat and repair data are for pre-tricuspid shunts. This is a case of a young woman who had a PDA and we catheterized her 3 or 4 times. And because we couldn't make up our mind whether we should be closing this PDA, which for some reason hadn't caused Eisenmenger syndrome in her 20s, but the pulmonary vascular resistance was only 6, dropping to around 5 with the reversibility. We got the courage, the QPQs was still high, 2.5, so we took the courage and closed this defect. And 1 year post-closure, PVR was 9. 9. Now, did we do a good thing? You could say no or yes. Anyway, 8 years post-closure, this is her. The RV looks good. She has pulmonary vascular disease, but the LV is not as dilated as it used to be, with a significant left-to-right shunt, and she's doing quite well with BNP of 21 on therapies. So whether we should be closing post-tricuspid shunts is a matter still of debate. The 4-strata risk score is not validated PHSD. There's lots of debate. We use the 4-strata with the WHO, functional class, 6-minute walk test, and BNP. It's very fashionable now. Most of the papers will give you data on this. For congenital heart disease, there's a recent paper by Michele and Alessandra Van Diesel and Italy and the Netherlands. And let's look at this. 223 patients, 68% Eisenmenger's, 5 centers. Survival did not differ between the risk groups, so this didn't really work. So they said, okay, fair enough. Let's go and revise the cutoffs of the walk test and other things. They revised the cutoffs, and they got the ROC curve from 0.65 to 0.71. Michele can tell me if he's happy with this 0.70 of. I think we need to work harder to find a better risk score for these patients. Now, I'm not going to go into much detail on other recommendations like avoiding pregnancy, like avoiding a routine phlebotomies. We need to be treating these patients PH therapies, and I'm going to skip that. I remind you that there are other types of PHESD. This is a Lecomte procedure. This is a TGA patient, arterial switch with no VSD who developed pulmonary vascular disease. So we need to be vigilant in these patients for pulmonary vascular disease to the point where the World Symposium said that we should be adding a group E for those patients. I'm not sure about that. But anyway, we need to be vigilant every time we scan all patients with repaired or even unrepaired congenital heart disease. We have clear recommendations on how to detect pulmonary hypertension, and we have written a paper many years ago now on how to identify PH in patients in whom these criteria that I showed you do not apply. For example, in patients with pulmonary atresia, with pulmonary stenosis, with univentricular circulation, and mastered systemic RVs and fontans. Finally, these patients are getting older, and more patients with heart failure coming. This is actually a young patient in her 20s with Eisenmenger AVSD, but torrential AV valve regurgitation. Look at the heart. And she's in trouble, and the transplant centers don't want to take her. So we have more and more patients with multi-organ failure, with renal dysfunction, which is of course a prognostic marker in these patients, and many patients who need transplant assessment but also need palliative care and continuous reassessment. I think I'm going to stop around here. I had some other cases I could show you, but this is just a case where this is another indication for transplantation because, as you know, we send this patient in transplantation and they follow routine standard criteria for listing patients. And I have this patient with a young patient, a 23-year-old, with an 8-centimeter pulmonary artery, which is going to burst. And when it bursts, that's going to be the end of it. And they put her on the transplant list on the elective, which means she's never going to be transplanted. And they can't get her on the normal transplant list. Unfortunately, we need to work harder to get our patients on transplant list. We need to work closer with palliative care. And I'm sorry, I've got too many slides, and we can talk about all these things. So increasing evidence. We know more about natural history. We know about avoiding pitfalls. We know about general management. We know about operability criteria, even though we're learning more and more. We need to prevent death and sudden cardiac death, and we will need to work on palliative care and transplantation for our patients. And I'm going to stop there because there's lots to discuss here. Thank you very much.
Thank you so much, Kostas. That was brilliant. So I'd like to welcome our panel of experts now. I'll let you introduce yourself, and if you just let us know where you're working so that the participants can know where to find you.
Let me start. My name is Michele D'Alto. I'm a cardiologist. I lead the PH unit in Naples, in south of Italy. I think that the presentation from Kostas has been a fantastic review of the problem of pulmonary hypertension and congenital heart disease. I think that nowadays the main problem, because we know it's very, very complex to manage patients with Eisenmenger syndrome, but the emerging problem is, for example, identifying and well-studying patients with ASD, because we have a lot of patients with ASD that are managed in centers that are not so skilled in congenital heart disease. So they decide to close or not hold ASD just based on feasibility of procedure that we know that is just an aspect, is not the main aspect of the problem. They do not perform because these people are diagnosed in adult age by chance. They do not perform a complete right heart catheterization evaluation. They ignore the QPQS. They ignore the PVR. They maybe do not know that if you close the hole, that they don't have an escape way from the right ventricle. Sometimes the problem is into the left ventricle, because if you have an ASD and you have a very high wedge pressure and close the hole, the problem should be also left heart failure with post-capillary pulmonary hypertension and pulmonary edema and so on. I think that this is an important issue. And we actually, I also like to ask Kostas about this. We don't know where is or if there is a no return point. I mean, if you have a patient with the borderline PVR between 3 and 5, that you are not sure what to do. How do you manage this patient, for example? What do you do? Do you use in your center that is maybe the leading center all over the world? I consider this the Royal Brompton Hospital. For example, do you perform some challenge with sizing balloon, with fluid challenge? Do you consider nitric oxide and so on? What do you do for this patient just to forecast what will happen and if he's sure to close or not the hole?
So let me start with nitric oxide in congenital heart disease. There's been lots of debate. Our pediatric colleagues still do nitric oxide and reversibility testing. Unfortunately, the evidence for what the nitric oxide tell us and how to interpret this is lacking. Indeed, as you very well know, the reversibility studies have disappeared from the guidelines, the congenital PH guidelines for congenital patients, and because we don't know how to interpret them. Also, in the context of what I said about de-recruitment of vessels and so on. So, even though we do nitric oxide, and it's more for academic reasons, and I find it very difficult. Maybe if we see a significant drop, it's reassuring. I must say, in our center, if we have a PVR of 5 or less, we will proceed in closing the defect. But what that tells us is that we need to be vigilant perioperatively and have a low threshold for starting therapies, which will certainly, if the patient they usually do well peri-closure of the atrial septal defect, but we make sure that they have a cardiac catheter within a couple of months. I'm sorry, within a couple of months from the closure of the defect, and if there is a high PVR, then we will have a low threshold for closing pulmonary for starting pulmonary vascular therapies. Now, the issue of ASDs closed right and left is a big issue. I must say that calculating pulmonary vascular resistance is one of the most difficult things you can do in the cath lab appropriately. whether you use the direct or indirect FIC. Many centers still use thermodilution, which according to the principles and the book should be used in patients with left to right shunt. A few patients have the ability to measure VO2 in the catheter lab to have a direct FIC. Fortunately, more and more centers, but only the specialist centers, can do hybrid catheters with MRI giving you pulmonary blood flow. But the confusion that exists in non-specialists still on the formula of pulmonary vascular resistance. So transpulmonary gradient divided by cardiac output. And when you ask colleagues who are non-congenital what the cardiac output is, and some people say QS. No, it's QP. I mean, it falls on to us, Michele, and the rest of the panel to educate our juniors, to educate our colleagues on the proper performance and interpretation of invasive hemodynamics. And every time the pulmonary vascular resistance is felt to be abnormal, they should be referring these patients to specialist centers instead of just closing the defect, because this is the easy and convenient thing to do.
Yeah, I absolutely agree. If I can complete also a concept, I think that a matter of debate should be also the age and the type of defect. I mean, giving the same hemodynamics in terms of QP, QS, or PVR is different having a young boy with post-tricuspid shunt that probably have a very nice probability is likely to recover the PVR if it's not extremely high. Of course, I'm still speaking on the left to right shunt. But from the other side, if you have a pre-tricuspid shunt in an older person in the 60s, for example, it's completely different. I mean, we are, at least in my center, a little bit more aggressive in younger people with post-tricuspid. But we are a little bit conservative in old people with pre-tricuspid. Otherwise, you know, in the study that the MUSE study that Costas showed, having a pre-tricuspid shunt is a poor prognosis marker. This is because the real Eisenmenger patient, I guess that Costas and you agree on this, is the post-tricuspid shunt patient that has been left in natural history. This is the real Eisenmenger with a great contractility of the right ventricle that is not so dilated, but is very hypertrophic. In pre-tricuspid shunt, you know, the remodeling is quite similar to idiopathic PAH. Sometimes, if you know, it developed by chance, should be a genetic background and predisposition. This should be a second hit, the presence of pre-tricuspid shunt. This is why these people having a poorer remodeling have a poorer prognosis compared with post-tricuspid.
I absolutely agree, and unfortunately, we don't have nomograms in saying what is a normal PVR in the 70-year-old versus the 20-year-old, and we still use the PVR of 2 now the same way. Is that correct thing to do or not? God knows. We still haven't got the data for that. The other thing to say is that the interpretation of cardiac catheter in older patients where there can be diastolic dysfunction, but then the cardiac catheter results depend on the level of hydration of the patient. So if you've left the patient waiting for your cardiac catheter nil by mouth for 12 hours, then you could find spuriously low wedge pressure and filling pressures. So I mean, you've published a lot on fluid challenges in these patients, and you're the world experts in that. And I think it applies to both non-congenital and congenital patients alike. Um, the fluid status of the patient. So you're probably more of an expert and you understand this better than I, because it's still a matter of debate and confusion even in our specialist centers of how to interpret catheters with shunts, with evidence of borderline diastolic dysfunction. Should I close the defect? Should I close it with a fenestration? Am I closing the fenestration because of pulmonary vascular disease or because of left-sided filling pressures which are likely to rise? Do I diurese the patient for a few days or a few weeks to avoid pulmonary edema if I'm closing the defect, and so on? So quite a lot of parameters which are not yet clear. Hence, again, specialist centers should be addressing these patients, not any center around the world.
Well, you, Sebastien, or I?
Maybe then I would like just to add a comment or a question to Costas based on this discussion about level to close the defect. On the other hand, in some situation, we face adults without experience as well who say, oh, my patient has a pulmonary hypertension with an ASD, so I do not close it without doing pulmonary vascular resistance, as you mentioned, or with calculation using thermodilation. And they, and on the other hand, they are sometimes too cautious and they do not close the defects that should clearly be closed. And this is also something we should point out. I think that patients with moderately elevated pulmonary vascular resistance, but still high overflow, clearly need a complete closure of the defect. And this is the only thing that will correct the evolution of the disease, if you agree.
I agree with that, and this is what I was saying about treat and repair. We have in the right ventricle which is working over time. If it's working against volume and pressure overload, that's not going to be good for long term. And therefore, we, on one hand, we don't want to be closing defects in the patients with significant pulmonary vascular disease. On the other hand, we don't want to leave open or completely open defects that are causing significant volume overload on patients. And again, what you're saying about pulmonary vascular resistance that can be misinterpreted. Colleagues using systemic cardiac output, so QS in the formula, and finding that the pulmonary vascular resistance is higher than it actually is, because you can have a systemic pulmonary blood flow of 4 and a pulmonary blood flow of 12, and hence that's going to really mess up your PVR calculations. Again, I don't understand why non-congenital teams should be closing defects. I know it's easy to deploy an umbrella right now, but I think there's room for error, and these patients should be coming, or at least seeking advice. There should be an MDT or a teleconference MDT where, Sebastien, you have once a month with a colleague and say, we've got these defects. What do you think about this and that and the other? And then you say yes or no, or follow them closely, because this could have a residual pulmonary hypertension. I totally agree with that.
Thank you, Costas, for the presentation and for the questions. I am Teresa Segura from Hospital de Octubre in Madrid, Spain. And I had a couple of comments regarding Eisenmenger patients, especially as you have said, true Eisenmenger patients, the post-tricuspid ones. So I think sometimes we are really focused on the right side and we start PH therapy, and sometimes we end up with triple oral therapy in some patients, sometimes even treprostinil, as you showed. But well, at least in my experience, sometimes, and as you said in your presentation, they end up developing some degree of heart failure, but not only right side failure, but also sometimes left side left heart failure. So, well, in my experience, it's important not to forget the left side, the left heart, and consider therapies such as dapagliflozin or AC inhibitors and so on, and they are sometimes useful, and because you see this LV, these dilated left ventricles in these post-tricuspid shunts, because it's their physiology somehow. It is as they started, and that's quite easy to it's an easy thing to do, and it's just to remember that there is the left heart there, and not only in AVSD patients where you have this left side AV valve regurgitation going towards the left upper pulmonary vein, so taking the patient to pulmonary edema. Not only those patients, but also like true single VSD patients, they sometimes develop this left heart failure. And well, I had a question on something I think I find interesting to discuss that you said about anticoagulation, that in our experience, we sometimes, or most of the times, we choose the low dose of NOACs. I don't know if that's what you do. It's a little like cooking, but that's what we do sometimes, or most of the times. And the thing about ASDs and treat and repair, and just I agree with your comments, and that's what we do. We are a little bit, we had usually be a little conservative, but we are moving towards this more aggressive treatment. And I agree with the concept of volume overloading, the volume overload of the right ventricle with the PH therapies, but I find somehow that the cutoff of QPQS of 1.5 is a little too little for some patients, and there should be kind of a correlation between the size of the ASD, Costas, and the QPQS. I mean, if you have a huge ASD, you expect the patient to have QPQS of 2, and then you certainly have volume overload problems. But sometimes you see those patients, as you said, with the large ASD or sinus venous ASD with the oxygen run is not well done. They have taken the saturation of the SVC somewhere below the pulmonary vein drainage, and they end up doing this Warden procedure with a QPQS of 1.6 and pulmonary vascular resistance of 4.7. And so my point is that the goal is not to treat and repair the patient, but is to save the patient from volume overload problems, just to think about it from a little more.
Save the patient from heart failure and the right side heart failure. And as you rightly said, there's no such thing as right heart and left heart failure. You've got Eisenmenger syndrome, you've got chronic cyanosis. I'm sure the myocardium of the left ventricle suffers from chronic hypoxia. Certainly may have suffered in the beginning of life if the post-tricuspid shunt was significant. But of course, if you have a patient with significant pulmonary vascular disease and still very dilated left ventricle with an VSD, PDA, you should be reassessing your QPQS, because you do have these patients with very compliant pulmonary vasculature even in their 20s, where the pulmonary vascular resistance is low, and that's why you don't expect LV dilatation, of course, in an Eisenmenger patient. So this is the concept of in the chest X-ray, no cardiomegaly. If you're an Eisenmenger, then you lose the dilatation, you lose the cardiomegaly. Now, you've touched upon a few things. So you touched upon the cardiac catheter, you've touched upon where we get mixed venous saturations, and of course, depending on the kind of where the shunt is, if it's a sinus venosus ASD with partial anomalous point venous retain, you certainly need to be going high up in the SVC. You need to be careful that if there is tricuspid regurgitation, the IVC, which you should be getting above the the hepatic veins, you can be contaminated by blood regurgitating because of the tricuspid regurgitation. So not easy. And of course, you have a left upper anomalous pulmonary venous drainage, then you can give up completely, because it's impossible to get a reliable mixed venous, and you probably need an MRI scan to help you with pulmonary blood flow and shunts. Heart failure, as I said, is not left or right side. It's usually right side in our patients, but we do have left ventricular dysfunction. Now, starting dapagliflozin is another thing. I don't disagree with you. There is zero evidence about it. Certainly, I wouldn't be starting ACE inhibitors or Entrestos and so on in Eisenmenger patients, because you tend, unless you have significant ventricular dysfunction, sometimes we have started that, but you really need to be careful. In small doses, you don't drop the systemic vascular resistance too much, and you cause further desaturation. These are things that you need to discuss on MDT and take very slowly and very carefully. But I have patients with Eisenmenger. I have 2 Eisenmenger patients with left ventricular dysfunction, with the akinesia of the apex, with no coronary artery disease issues, with a clot in the apex of the LV and chronic systolic dysfunction, which can only be the chronic cyanosis and the chronic overload and the general low cardiac output and God knows what else. So you need to look at the right and the left. You're absolutely right. I can't remember what else you said, but you went through the whole the whole spectrum of issues that we have.
May I add a comment on this?
Yes.
Yeah, I absolutely agree. Actually, I think that in people that is interested in pulmonary hypertension in general, and particularly if you are interested in congenital heart disease and pulmonary hypertension, there's something that is paradoxical because cardiologists forget the left ventricle. This is strange because, you know, the forgotten chamber became the left ventricle just once. So you are, Teresa, absolutely right in this. The problem is that, for example, we have the same opposite problems that we have in post-capillary PH. What I mean, if you have a patient with left heart dysfunction and post-capillary pulmonary hypertension and the dilation of the right ventricle, you cannot use drugs for PAH due to the risk of pulmonary edema because you have a very high very high telediastolic left ventricular pressure, so it's not allowed giving something that increase the diameter of arterial because the risk of pulmonary edema is very high. So the real setup is optimize the treatment for left heart. The opposite, if you have an Eisenmenger patient and you have a dysfunction of the left ventricle and not only the right ventricle, you have the opposite problem because if you want to decompress with vasodilator, ACE inhibitors, ARNI in general, the left ventricle, you have the problem that you increase the probability of a right to left shunt that became massive. So you should have a massive desaturation. That's the reason why systemic vasodilators are not a good choice in patients with Eisenmenger syndrome. So you have so once again, you have to, in this case, you have to reduce the afterload of the right ventricle because this is the origin of the disease. So it's the opposite condition. So for patients with post-capillary PH, it's not a good choice using PH drugs. For patients with Eisenmenger syndrome, it's not a fantastic choice to use a vasodilator for systemic circulation.
Yeah, I agree. But sometimes you do like in little doses in both cases.
Yes, maybe glyphosate should be, but as Costa said, we wait for data because it should be a good choice.
Yeah. And also, if I have a last comment, just or it's more like worry to share with you. It's that some of these patients with large ASD and severe pulmonary vascular resistance that you start giving them PH therapies and pressure, they don't go down a little and QPQS is high, but pressures are with, imagine PVR about 8 with units. So in my experience, many times, you end up with quite high QPQS, like over 1.7 even, and or around 1.5, 1.6, let's say. And the RV is becoming larger and larger, and so you don't know when to end or finish giving them PH therapies, and like not be so stressed about lowering pulmonary vascular resistance, but they like be calm somehow and let them stay in that way, because otherwise you are precipitating volume overloading the lungs and the RV. So sometimes I have the feeling that you have to give vasodilators very slowly and not to rush in giving them these therapies in order to lower pulmonary pressures, because you never get to this point and you are overloading their hearts. I don't know what's your feeling about that. If you end up like listing them for transplantation, for bilateral lung transplantation and closure of the AC, for instance, and like earlier somehow, when you give them like very quickly the therapy. You are mute.
You're muted.
You're talking about single ventricles here, no?
No single ventricles. Single ventricles, it's another thing, of course.
So overload. I mean, the balance. We can be talking about this for ages, but the balance of hemodynamics has to be kept in mind when we send the patients for transplantation. I know in Spain here transplantation has been very disappointing, I must say, and we've hardly any managed to transplant any Eisenmenger patients. But I know in Spain you're much more adept in doing that. So I'm not sure how to answer that, but anyway. Melissa, I really need to go now because they're waiting for me for 6 minutes in the other meeting. So I don't know if we want to conclude.
Okay, thank you so much, everyone. Sebastien, we'll discuss. We'll probably have another session talking about transplantation and things like this. But I'd like to thank you all for joining us today. I hope you found it all educational. I think it sounds like the key message is that these patients are very complex. They are becoming more adult, more of an adult issue, I suppose. And that we shouldn't be treating them alone, and that we should always be referring for specialist centres' opinions and MDTs. Thank you all, and I hope to see you next time.